So hello and welcome to the Toronto Centre for Neonatal Health and the first of our Spotlight interview series. My name is Caroline Ahern. I'm currently the Senior Transport Fellow with the Acute Care Transport Service at the Hospital for Sick Children in Toronto, and I'm delighted to be interviewing Dr. Hilary Whyte, who's our great mentor and has been leading our acute care transport service now for over 20 years. Dr. Whyte, thank you very much for joining me. I'd love to start by just asking you what drew you to neonatology and transport medicine in particular.
Right, thank you, and thank you, Carolyn, for inviting me to interview with you this morning. Well, I guess it began with my decision to leave Dublin, Ireland, where I had trained in pediatrics, and I had already spent a year of neonatology as a registrar in the Rotunda Hospital. And I came to get my BTA, that's my Bean to America degree. And in my second year of neonatology, which I elected to do out in Vancouver at BC Children's Hospital, I was introduced to transport medicine. Back then, in the 70s and 80s, there was no transport system in Ireland or the UK, so it was unfamiliar territory to me. I was one of 5 fellows in BC Children's Hospital. 2 of us were seniors, that is, we were in our second year, and Don and I were granted the privilege of every alternate day taking transport call on top of our NICU call. So you can imagine back in those days, it was quite busy and there was lots and lots and lots of call and lots of hours worked, but it was a tremendous learning experience. Their transport program was a neonatal transport program, neonatal only at that time, and it was built on critical care paramedics serving the entire province, both by land and air. And because it was a relatively young program in its own development, I was, and Don, my colleague, was often asked to go out on transport with the medics. So any very premature baby, any very sick baby, multiples, of course, any reason for having a third set of hands and maybe more cognitive competencies, I was involved in transport. So I literally did, I would say, hundreds of transports during that year. And I fell in love with transport medicine. So when I was offered a staff job back at Sick Kids, I had to go through the paperwork, of course, being an IMG, which took almost a year to come through. And so during that year, I was a senior fellow, junior faculty in the NICU at Sick Kids. And I was keen to really build on the transport program, which was at that time quite embryonic in Sick Kids. And so with, again, another senior fellow, Warwick Butt, and myself, we elected to go on a lot of transports and really build up the competencies of the RNs who were at that time the mainstay or backbone of the transport program. So that was the early beginnings of transport. I really didn't have a mentor in transport medicine per se, but there were a couple of people along the way that were very meaningful in being colleagues that also were keen and interested in transport. One being Dr. Andrew McNabb from BC, and also Dr. Andrew Berry from New South Wales, from Sydney, New South Wales, that serviced their programs. And so we've kept in touch over the years, and we've kind of grown together. I hope that answers the question, Carolyn.
Absolutely. And I suppose then, as you've transitioned into becoming medical director of the acute care transport service, what have been some of your biggest challenges you've had to face?
Well, first of all, I never contrived to be medical director. That was really quite a surprise. When I went on faculty at Sick Kids as a neonatologist, my passion and love had always been in the care of babies to try to prevent brain injury. And so I had a passion and interest in preterm babies and IVH, PHVD. I was very, very interested in the care of the HIE population. And so during that first decade of my time at Sick Kids, I actually was the medical director for the follow-up program, which is kind of the other end of the spectrum. And I went off on a sabbatical in order to gain more expertise in epidemiology, statistics, being able to do more measurement of outcome, and came back poised to have a career that was more research focused. When a knock on my door from the CEO, Mary Jo Haddad, asked me if I would be willing and interested to take over running the transport program, and it was like, me? Oh, okay. Let me think about that. And so it didn't take me very long to say yes. But there were some conditions involved. And hence the answer to your question, what were the barriers? Well, I saw that the program was grossly underfunded and poorly supported. And so I insisted that we have a role for a manager, a role for an educator, a role for RTs on the team, so we could expand our mandate beyond the care of the newborn, because obviously at that time we had a lot of infants, toddlers, children that were being poorly managed in transport as well. And so back in the late 90s, around 2000, I really pushed for extended program, enhanced resources, and even wrote a proposal to the ministry for fellows. And back in 2000, they granted me funding for fellows to come on board, and an extra neonatologist so that I would have some help, because it was a 365 days a year on-call passion. So I think the biggest barriers have been achieving appropriate funding for the program. I would say the barriers really fall into three buckets, and that would be areas for improvement in clinical care. And that really is about reflective practice, outreach education, supporting the community, and recognizing that what's commonplace for me today is very rare for them tomorrow. And so I'm talking about community colleagues, whether they're pediatricians or GPs in practice. It's a very different story when they're faced with a very sick patient. I think the second bucket, I would say, is around barriers in process. And of course, these are things that we have some control over, such as dispatch and mobilization times, stabilization times. These are all things I've really had to focus on, and I've really worked hard to improve, because when you're in the community, the only thing you care about is response time. How quickly can you get some help there? And then I think the third bucket is really around systems. And in that bucket, I would put, support of land ambulance services, support of air ambulance services for our hospital-based teams, and equipment compatibility. And that has been an enormous task to actually achieve appropriate safe equipment for transport of newborns in particular. They're very vulnerable and really need a full intensive care, which is mobile. And it's taken years to build the appropriate standardized, certified equipment, and we still have challenges. So I think it's ongoing. It never seems to go away. When you fix one problem, there's another one waiting to be fixed or waiting to be solved. So it's an area which continues to evolve, Carolyn, and where I can see there's still a lot more to be done.
Fantastic. And what advice would you have for trainees, residents and fellows coming up and starting their career and looking to a future in neonatology?
A great question. Well, first of all, I would say you have to find neonatology in whatever branch of neonatology you manage to find your passion. You've got to find your passion for work not to feel like work, and for the notion that after 4 decades of practice, you still look forward to coming to work is based on the fact that I found my passion. I wasn't always clear on the fact that I wanted to be a neonatologist. On the contrary, I thought I wanted to be a surgeon. And then I thought pediatric surgery. And then I thought, well, I'm enjoying peds more. And then because I was technically fairly proficient, good with my hands, good with skills, I really recognized I was very much enjoying neonatology, where I could stay a generalist, and really enjoyed acute care medicine. So this is not for everybody. If this is not something that you really look forward to coming to work to do, then neonatology is not the right job for you. There's clearly lots of stresses involved. It can be very frustrating and very sad and very disappointing when you can't make a difference. But the reality is you make a difference so often that it's a very rewarding career as well. I mean, the branch of transport medicine is also not for everybody, but there are so many aspects to neonatology because it is a general area of interest that I think most people who enjoy acute care medicine will enjoy neonatology.
Great. And so finally, just to round up, what does the future hold for you and for transport medicine?
Well, I'm not done yet. Much more of the same, I would say, continuing to build the transport program locally at Sick Kids, providing leadership in the province, which I've certainly had the privilege of doing over the last decade or more, providing leadership across the country and indeed beyond. I mean, it's a small group of neonatologists and pediatric intensivists, because don't forget the ACTS team is a 0 to 18 retrieval service. So we go far beyond the newborn period. And my colleagues across the world who are involved in transport medicine are great about staying in touch. And now that we are so familiar with virtual platforms and indeed even virtual care, I think that it's easier for us to stay in touch and help each other to see opportunities for improvement. Most importantly, what I would like to achieve is more of a telemedicine program built out on the back of the consult service we have for both newborn and children. I'd like to see our outreach program funded and developed. I'd really like to see us do an awful lot more outreach education than we do today, because all of this work has been off the side of our desk with no funding, no infrastructure. And so there's a ton more work to be done. But it's a very exciting future, and prospects are, I think, very good. Thank you.
Thank you very much, Dr. Whyte, and thank you for talking to me today and sharing your passion for neonatology and for transport medicine, and for all your mentorship and leadership of the acute care transport service.
Thank you.
That's all from me, but thank you very much.
My pleasure. Thank you very much, Carolyn.